Next, we're talking about neuropsychological evaluations utilities. So Dr. Siegel just talked about clinical trials. In clinical trials, neuropsych evaluations are done and in a lot of that to see if things change over time. So we're going to have Dr. Natalie Berger discuss a little bit about what those mean and what the pros are for them. She's a pediatric neuropsychologist and assistant professor of psychiatry at Rush University Medical Center in Chicago, Illinois. So welcome, Dr. Berger.
Thank you so much. Is everyone able to hear me? Good.
Yes, we can.
Wonderful. Thank you. Well, I appreciate you all joining us this morning. I think this is going to be a really nice follow-up to the discussion that was just had in terms of the different neuropsychological phenotypes that are associated with the different genetic syndromes that we're going to be talking about today. So I'm going to be talking about neuropsychological evaluation and the purpose of that. Given that this is a family conference, I really want to make sure that this is useful for all of you. So at the end, I definitely want to make sure that we're saving time for questions, but I also will put my email address up. So if you do have more individual questions that you would appreciate follow up on, feel free just to shoot me an email after the talk, and I'm more than happy to discuss more individual feedback with you. So as we jump in this morning, what do I mean when we say neuropsychological evaluation and neuropsychological assessment? Truly, what is neuropsychology? So neuropsychology focuses on the impact of brain differences on cognitive, behavioral, and emotional functioning. And really at its core, neuropsychology is the link between brain and behavior. And when we're thinking about neuropsychological assessment, we're really thinking about what does the genetics say about how an individual's brain works, and what does that translate into in terms of the cognitive phenotype, the behavioral phenotype of a particular individual. So as a clinician, a clinical neuropsychologist really can focus on assessment, where we're trying to evaluate an individual's strengths and weaknesses, but also it can include the management and the rehabilitation of some of those areas that are impacted based off of the brain differences. It's also important to keep in mind that neuropsychologists have particular expertise when it comes to really integrating across a number of different fields. So part of our job in the clinical realm is to integrate the medical, the psychiatric, the occupational aspects of rehabilitation in order to effectively treatment plan. So for many individuals, I'm sure you've already had children who go through neuropsychological evaluations. I think the biggest piece and the biggest benefit of a neuropsychological evaluation truly is to what degree does it inform treatment planning and help you better understand your individual child's strengths and weaknesses, and then figure out what can we do to utilize those relative strengths and maximize even further and optimize the developmental trajectory of that child. So let's briefly go through the neuropsychological phenotypes that are associated with the different genetic syndromes that you are all representing today. So we're going to start with Dup15q because that's the area that from a neuropsychological perspective, honestly has been the best researched. When we think about the neuropsychological phenotype associated with Dup15q, we're thinking about the interplay of a number of different domains. The first is oftentimes going to be the motor domain. So Dup15q is really characterized by hypotonia, gross and fine motor difficulties. I would say a variable intellectual disability, oftentimes autism spectrum disorder and epilepsy. When we think about epilepsy for Dup15q, we're really thinking about this starting with infantile spasms. Sometimes this can progress to Lennox-Gastaut. But I think one of the biggest hallmarks, not just of Dup15q, but also of Ring 14 and 8p, is the fact that the clinical findings may differ quite significantly between people. And even among individuals within the same molecular grouping, they have similar duplications based on breakpoints. We get a different neuropsychological phenotype. And so even though we're talking about some of these overall profiles at a group level, it's really important to think about what does this look like for your individual child? And again, coming back to some of those individualized recommendations and treatment planning. Diving into some of these phenotypes in a little bit more detail, when we think about motor skills, hypotonia and newborn infants with Dup15q, oftentimes associated with feeding difficulties and gross motor delays. We know that childhood hypotonia can really impair motor development, but most children with DUP 15Q do go on to walk and ambulate independently, although, as I'm sure you all know, a wide base or an ataxic gait is relatively common. I want to talk a little bit more about kind of developmental delay and intellectual disability. So in DUP 15Q, delays in early childhood development is extremely common. When we're thinking about developmental delays versus an intellectual disability, this is to some degree an issue of semantics. So we don't diagnose an intellectual disability prior to the age of 5. So oftentimes for young children who are being evaluated during that early childhood period, they may be diagnosed with a global developmental delay after age 5. That's just changed in a terminology to an intellectual disability. Really, what we're saying from a diagnostic perspective is just that the way the child learns is a little bit different. And they may need a different teaching style in order to benefit from school and to benefit from intervention. But it doesn't mean that the child can't learn. It just means that they're going to need more help and support in order to learn long term. Speech and language is an area that is often quite impacted. And I think that's something to really keep in mind because functional communication, whatever that looks like for your particular child, is going to be really important to monitor, track, and figure out what can we do in order to promote optimal communication. Autism spectrum disorder is obviously something that I think many people are aware of, and we'll talk a little bit more as we go through this morning what autism spectrum disorder can actually look like, because it does present a little bit differently depending on the particular genetic syndrome. But most people with DUP 15Q do meet criteria for autism spectrum disorder. We really think about DUP 15Q as conferring quite a bit of risk for autism spectrum disorder. And so the odds ratio for autism within DUP 15Q is actually about 40 times higher than in the general population. But we'll talk in a little bit more. The phenotype of autism within DUP 15Q is a little bit different. When we think about epilepsy and DUP 15Q, this is an area that we certainly want to be very mindful of. When we think about treatments for DUP 15Q, obviously we don't have something targeting DUP 15Q in particular, but we do want to make sure that we're getting seizure control as much as possible. So as I just mentioned, infantile spasms is one of the most common early presentations. Oftentimes that progresses into other types of seizures as well. We really want to be cautious here of monitoring the epilepsy history because intractable epilepsy in DUP 15Q can result in secondary effects over and above DUP 15Q itself. So for example, status epilepticus can be associated with a developmental regression or falls associated with more significant seizures. So that's something to be working very closely with the neurology team to make sure that we're understanding and doing the best that we can to control those seizures. Moving on to ring 14, I want to point out, given that this is a cross syndrome context or cross syndrome conference, excuse me, you'll notice that I'm hitting these same areas. This is because even though the genetic mechanism for all three of these syndromes is quite different, we're getting similar phenotypes. And I think this is really important for both clinicians and researchers. And the reason that it's so important is because as we're looking more at these mechanisms and relating the genotype to the phenotype, it's really important for us to think about what are treatments that might benefit multiple syndromes simultaneously. That can really help when we're thinking about not just applying for grants on a research perspective, but also how can we leverage all the wonderful insight that families have and what is most meaningful in terms of differences in the quality of life for your children. So I think thinking about things from a cross syndrome perspective is really, really important here. So when we think about ring 14, again, we're thinking about similar difficulties when it comes to motor concerns. Hypotonia is extremely common in ring 14 as well. In ring 14, hypotonia actually tends to decrease a little bit over time, but it does depend a little bit on the early rehabilitation. Similarly, we're seeing a high percentage of developmental delay and intellectual disability in ring 14. Ring 14, it's relatively consistent that patients tend to have moderate to severe intellectual disability. And here, an important factor is the interplay between cognitive functioning and seizure history. So, one of the things for Ring 14 in particular is that the severity of the intellectual disability or the severity of the developmental delay to some degree is related to the onset, so the age of onset, and the seizure severity or frequency, where earlier onset of seizures is related to a higher degree of disability and the presence of autism-like traits. So this is really important when we think about seizure control, because for Ring 14, the seizures present differently than they might present in Dupe 15q, where for Dupe 15q, oftentimes it's infantile spasms that progress to other seizure types. Ring 14, oftentimes we're seeing the epilepsy being a little bit more related to recurrent infections and febrile seizures. We want to make sure that we're getting those seizures under control as much as possible in order to hopefully decrease the likelihood of further cognitive decline related to seizure history. So there's quite a bit of interplay here. Do 15q, certainly there's some research that suggests that the more severe epilepsy presentation, the more severe cognitive difficulties. But again, this is a complex interplay of factors that we want to make sure that we're working as part of a multidisciplinary care team to really make sure that we're supporting your child from a neurological perspective, a behavioral perspective, a school perspective, to just optimize their developmental trajectory long term. I think one of the things to keep in mind when it comes to autism symptomatology in Ring 14 is it's a little bit less clear than in Dupe 15q. So autism phenotype in Ring 14, oftentimes we're seeing elevated levels of autism symptomatology, but individuals with Ring 14 may not always meet criteria for an autism spectrum disorder. This is important for us to think about because it does actually have treatment implications, but it also helps us to better conceptualize your individual child's needs and what are things that we can prioritize from a treatment planning perspective. So when we think about 8P, 8P is a little bit different because simply there is not as much research looking at 8P, which is really unfortunate. The research that is out there, again, tends to find very similar areas of difficulty, although the presentation certainly seems less consistent across individuals. The most common clinical manifestation is again going to be developmental delay, a mild to severe cognitive deficit. We're seeing continued difficulties when it comes to expressive speech, language, and then that early hypotonia that can contribute to a psychomotor delay. I think one of the things to think about here is that about 30 to 50% of individuals with a chromosome 8p disorder or syndrome do meet criteria for autism, but the autism presentation can vary quite dramatically in 8p, all the way from individuals who are very mildly affected with autism symptomatology to more significant autism symptomatology. I think one of the things to keep in mind too is the epilepsy presentation is quite variable. Even though individuals with 8P have an elevated risk of seizures, it's not as consistent of a seizure profile. And when I think about 8P and the neurology and the neurological findings that are associated with 8P, I tend to think more consistently with agenesis over the corpus callosum and the behavioral effects of that. Oftentimes, even for individuals without a genetic condition, agenesis of the corpus callosum can present with autism symptomatology. And so that's something to think about for 8P in particular, that we want to continue to manage seizures, but we also want to think about the interplay between the neurodevelopmental sequelae associated with agenesis of the corpus callosum. I want to just briefly kind of sidetrack here and go through autism spectrum disorder in a little bit more detail. And the reason for that is because, as I'm sure you all know, autism spectrum disorder cross-cuts all of these genetic syndromes. And so when we say autism spectrum disorder, what does that mean? So, when I am working with an individual with a genetic condition and autism spectrum disorder is associated with that genetic condition, I want to make sure that I'm understanding what that presentation looks like, whether that's consistent or inconsistent with what we call non syndromic ASD. And then what can we do to make sure that we're really maximizing, again, that developmental trajectory for that child based off of their unique constellation of symptoms. So, in order to meet criteria for a formal diagnosis of autism spectrum disorder, a child needs to have difficulties in two areas. The first area is going to be social communication. And when I say social communication, we're thinking about things like deficits in social emotional reciprocity, that back and forth. Maybe not being as interested in peers as you might expect based off of their developmental level, not chronological age. This would also include things like reduced nonverbal communication. So, eye contact that is atypical for the child's developmental level, not using gestures as frequently as we might expect based off of their developmental level. This is also going to include difficulties in developing, maintaining, and understanding relationships. So, that back and forth relationship with imaginative play, making friends, things like that. That's that social communication piece. The second piece is going to be RRBs, or restricted interest repetitive behaviors. This is something where repetitive motor behaviors, so motor stereotypies, repetitive or idiosyncratic language falls under this category. This would also include cognitive rigidity, insistence on sameness, things like lining up toys, really restricted interests where a child may be very, very interested in Thomas the Tank Engine, much more so than you might expect for another child with a similar level of developmental functioning. And then also unusual or atypical sensory presentations. So looking at objects very, very closely, perhaps out of the corner of their eye, having very particular reactions to specific sounds like a blender or something like that. If a child has difficulty in both the areas of social communication and restricted interest in repetitive behavior, that's when we get a formal diagnosis of autism spectrum disorder. And so you can see for all of these different genetic conditions that a child may have aspects of these autism symptomatology. So they may have subclinical autism traits and not meet criteria for the full diagnosis. And this is really important for us to think about because we are going to approach treatment differently depending on whether a full diagnosis is appropriate. A big thing to keep in mind here is to what degree is a formal diagnosis of autism spectrum disorder going to help with treatment access? In some states, it's really important to have a formal diagnosis of autism in order to qualify for particular types of services. So that's something just to really keep in mind to make sure that you understand the regulations in your state and how that interplays with the availability of particular treatments. We want to think about this then in particular relationship to the genetic condition. So I'm going to use DUT15Q as an example, again, because it's been more widely studied. So we know that DUT15Q is one of the most common syndromic forms of autism spectrum disorder. I think one of the things that's important to know here is that autism trait severity is actually less severe in DUT15Q than in non-syndromic forms of autism. And the reason for that is because in DUT15Q, we actually see a relative strength when it comes to social interest. However, we see greater impairment in motor skills and daily living skills. This is important because when I'm assessing for the presence of autism spectrum disorder in a patient with DUT15Q, I'm expecting things to be a little bit better when it comes to social smiling, when it comes to shared enjoyment, when it comes to shared interest in activities and joint attention in this particular population. However, I'm also going to expect some of those nonverbal things that are motor dependent to be more difficult for these patients, not because of autism, but because of the motor difficulties associated with the DUT15Q. So it's important then if a child, for example, is not pointing, for me not to necessarily consider that part of an autism trait, but rather consistent with what we know about the motor presentation of DUT15Q. Simultaneously, if a child has an intact social smile in DUT15Q, that shouldn't say, oh, well, then they must not have autism spectrum disorder, because we see some of these unique profiles of strengths and weaknesses. What does this then mean for treatment implications, right? This means that we need to have a very early and consistent focus on those motor skills, and that also we can take advantage of this relatively intact social interest and social motivation to really leverage joint attention and language within a play context. So we're going to take a little bit of a sidetrack here for a couple of minutes and talk about treatments for autism spectrum disorder. So autism spectrum disorder, when we think about gold standard treatments for autism, one of the first things, if you Googled this, that would come up is applied behavior analysis, or ABA. Applied behavior analysis is just a general learning principle. What this is this is a field of treatment. So it's very broad. It's not one particular type of treatment, where an intervention is based off the principles of learning theory and reinforcement. The goal is to improve socially meaningful quality of life changes that are going to make a difference in the day-to-day function of your child, like functional communication, like daily living skills, like social skills. There has been extensive research over the past 40 years that have documented the effectiveness of ABA in many different kinds of populations, being done by many different types of interventionists, in many different types of settings, and targeting many different types of behavior. One of the things, though, that I want to kind of keep in mind is that ABA has been around for a long time. But that being said, there are so many different types of interventions that are embedded within ABA that I do think get a little bit lost, but that it's really important when we're thinking about working with individuals with different genetic conditions to really be specific about, okay, what's the type of ABA that is going to be most effective or most meaningful for that particular child? So if we think about DUT15Q and the strengths associated with DUT15Q when it comes to autism symptomatology, we know that they have a lot of social motivation, and we know that there's a higher level of social functioning. So what that means is that individual with DUT15Q, ideally, if they're meeting criteria for autism spectrum disorder, are going to benefit from treatments called NDBIs. NDBIs are naturalistic developmental behavioral interventions. That is a mouthful, I know. So we're going to kind of break that down into individual parts. What NDBIs do is they take behavioral ABA principles and they embed them in a naturalistic developmental context. So we're using strategies from the developmental literature that are developmentally appropriate, things that are working towards increasing responsiveness, social engagement, motivation to communicate. And then we're embedding behavioral strategies on top of that to teach new skills, providing opportunities for success. And then all of this takes place in a child's naturalistic context in the context of meaningful interactions. So this is great because then we can take advantage of all of the wonderful strengths that are associated with DUT15Q and use those to build upon to really help support things like functional communication. So when we're thinking about treatment matching, it would be ideal if we could think about this at a very individual level. Instead, we're thinking about this more right now with the research at a group level. And what can we do to really build towards what's going to be most appropriate for your individual child? And so if you do have a child who's receiving ABA or applied behavior analysis intervention, I'd really recommend reaching out to your provider and asking about their familiarity and use of naturalistic techniques. I'm going to skip this just for the sake of time, but in general, NDBIs are working on the same kinds of skills, just in a developmental sequence. From a practical perspective, what do we think a neuropsychological evaluation should include for individuals with different genetic syndromes? We really recommend a comprehensive review of the medical history in order to integrate the really nuanced medical information of your particular child with the test results. We want to make sure that we're always assessing the developmental and cognitive level of the child, which includes language functioning, motor functioning, because that's a common area of difficulty for these patient populations. It should include a measure of autism symptomatology, adaptive functioning. Depending on your child's skill level, it may also be appropriate to assess things like memory, attention, and executive functioning, but that's just going to depend on the age of your child and the cognitive functioning level of your child. But at the end of the day, the most important thing is that you leave a neuropsychological evaluation with recommendations that are individualized to your child. So you feel like you know what to do in terms of next steps to optimize that developmental trajectory for your child. So I think the next question that often comes up is when and why should I have a neuropsychological evaluation? And there's really two different ways of looking at this. The first is really thinking about, okay, just different points in time. So if we start birth to age 3 with early intervention, it can be really helpful to have a neuropsychological or developmental evaluation at this stage, because this is when we can start to look at baseline functioning across all of these different domains. We can really work to connect a family with early intervention and private therapies. And also, ideally, we're assessing for autism symptomatology prior to age 3. Early identification and intervention prior to age 3 makes a big difference because we know the brain is more plastic earlier on in development. And we know that there are early behavioral markers of autism symptomatology that if we can catch it early, we can do autism specific interventions, which can then have downstream effects later on social functioning, language functioning, cognitive functioning, and behavioral functioning. And so we're really hoping that through early diagnosis and early intervention, we're having these specialized interventions that can mitigate to some degree the later presentation of autism symptoms. We could also do a neuropsychological evaluation in the preschool period, at which point, if we had not done one early on, we want to kind of do the same thing that we would have done at birth to 3, but we want to support IEP development through school, continuing on with private therapies. I would also recommend then a evaluation during the early childhood period, because this is when we're going to start to formally evaluate cognitive abilities, refine an IEP and private therapy recommendations. And then I really recommend during the transition age. And the reason that this is important is because we want updated cognitive testing to figure out where is the child functioning during this transition to adulthood. And it's also really important when it comes to thinking about service access. Okay, as my child turns 18, we need to apply for legal guardianship. Sometimes a neuropsych evaluation is required as part of that legal process. Certain states and certain services depend on having updated testing results when it comes to cognitive functioning in order to apply for residential treatment and residential programming, day programming, things like that. So it's really important during that adult transition period. Another option is thinking about it in terms of benchmarks rather than age. So it can be helpful at time of initial diagnosis. This is going to be similar to that birth to 3, where we want to establish baseline functioning across domains, determine what services are going to be appropriate, and refer accordingly. I would also recommend thinking about an evaluation after initiating a new treatment. The reason for this is that we want to know, is the treatment helping? Treatments are oftentimes very intensive, both from a time perspective, an effort perspective, and monetarily. If it's not working, if it's not improving skills, we need to know to pivot. So I think it's really important to think about measuring treatment and treatment success and treatment progress. On the other hand, certain, for example, anti-epileptics can have neuropsychological effects. So I think it's important for us to think about, is a treatment having side effects? So we can also look at neuropsychological evaluation to support that. If you have concern for a skill regression, that's going to be really important for a neuropsychological evaluation. We need to be able to capture a skill regression as soon as possible in order to course correct. This is going to then help us compare to baseline functioning and then refer again for appropriate services and to tweak some of those treatment planning recommendations. The other potential reason to do a neuropsych evaluation that's not tied to age or development is service access. So if your child has a diagnosis of autism spectrum disorder and is receiving ABA services, some insurance companies require updated autism testing every 3 years. So naturally, if you're required to do that for insurance, that's going to be a reason to be going through a neuropsych evaluation. And then, like we already talked about, adult supports. It's really important to have updated testing upon that adult transition period. This is just the last area that we will go through very quickly. I think one of the things to keep in mind is that you want to make sure that you're seeing a provider who has expertise in the types of presentations that are common in different genetic syndromes. Neuropsychology has many different types of specialties, and I would not be the person to go to if, for example, your child had leukemia and you needed to know the neuropsychological effects of that, right? You want to make sure that the neuropsychologist that you're seeing has expertise in the types of questions that you need answered for your child. So the first question that you want to ask is, what is your experience working with children with rare diseases or rare genetic syndromes? Does that provider have expertise in conducting developmental assessments for older children? So many neuropsychologists, they may work with young children and they may work with older adolescents, but they may not have as much experience working with more significantly impacted children. So you want to make sure that that particular provider does developmental testing and is comfortable doing developmental testing with older children and working with minimally verbal individuals. You also want to make sure that that provider has extensive experience in documenting and understanding autism spectrum disorder with comorbid intellectual disability. Autism presents differently in genetic disorders, and it presents differently with comorbid intellectual disability. You want to make sure that provider truly understands what that presentation looks like in order to not miss a diagnosis of autism or overdiagnose autism if it's not there and just better explained by some of the cognitive difficulties. If one of the goals is tracking change over time and progress over time, is that neuropsychologist comfortable in documenting change over time in individuals who have cognitive delays? This looks different than how we might track change over time in an individual without cognitive difficulties. And so you want to make sure that they're aware of, for example, growth scale values. Are we tracking age equivalences, raw scores, making sure to include some of that additional information in the report so that way we're not missing out on important information that can help us down the road track and evaluate change over time for your child. And then does that neuropsychologist provide individualized recommendations for home and school? I think it's really important to be able to provide concrete information about your child's learning styles. What can we do to really identify those strengths and capitalize on those strengths? So that way, day to day, we're making a meaningful difference in your child. And then is that provider willing and able, if that's something that you are interested in, to support your child's school team in terms of drafting an IEP, participating in IEP meetings, and supporting recommendations? So I know we are a couple minutes over and I apologize for that, but are there any quick questions? I'm also, like I said, happy to answer any questions via email after the fact.
Excuse me, there are a couple questions. I think we have the next speaker on, but we'll take these questions first. I think he's good to wait a little bit. So
Thank you so much. I appreciate it.
First was from a parent. Could someone ask the medical specialist about supplementing? Oh, Mark, I don't know if this is for you, with alpha GPC and creatine for memory and focus.
I probably will not be the best person to answer that.
Okay, Mark, I will give that to somebody else. You mentioned that ring 14 usually presents with moderate to severe intellectual disability. What range of intellectual disability does Duke 15Q usually result in?
That's a really great question. It's variable when it comes to Duke 15Q. It typically is more in the moderate to severe range as well, but like I said, it's variable. So you do have individuals who are more mild in terms of cognitive difficulties and all the way to the profound range. I think one of the things that's most important is not necessarily the category of intellectual disability, but more thinking about just what are the level of supports that your child needs and what can we do to best support your child day to day. We really just want to think about what can we do to maximize their functional communication and their independence.
Great. Can you be more specific on a development strategy coinciding with the behavior strategy?
Yes, that is a really wonderful question. So, when it comes to interventions, specifically for NDBIs or naturalistic developmental behavioral interventions, we want to think about where is your child at developmentally. We know that even for children with significant cognitive delays, that they still achieve their milestones in a standard timeline. So, for example, a child is not going to start talking verbally until they master some of these early emerging nonverbal skills. So we want to think about embedding this developmental framework within a behavioral model. So that way we're targeting appropriate skills before we're starting to think about some of these more advanced skills. So it's all about meeting your child where they're at, thinking about what are your goals as the parent, and then how can we design a treatment plan using behavioral principles that is embedded within that developmental context and takes advantages of the really nice strengths that your child brings to the table.
Great. Can you talk about what social communication disorder looks like for a child or a teen who's not diagnosed with ASD, and what treatments and therapies and interventions are most helpful?
Yeah, really nice question. So, social communication disorder differs from autism spectrum disorder specifically because social communication disorder does not have RRBs. So, when we think about making that differential diagnosis, an individual with a social communication disorder struggles in many of the same areas socially and communicatively as an individual with autism, but there is not the presence of sensory sensitivities, repetitive motor stereotypies, things like that. So, from an intervention perspective, we oftentimes think of similar interventions as being very helpful. We just wouldn't focus as much on the behavior because that might not be an area of difficulty. But we would want to be able to support, based off of where your child is at developmentally, their ability to communicate nonverbally. Do they understand nonverbal communication of other people? Are they able to use nonverbal communication appropriately? Can they engage in back and forth conversation if that is developmentally appropriate for that child's language level? So the intervention is much more focused on social skill development and nonverbal communication rather than focusing on some of the other behaviors that are more associated with autism.
Thank you. That was a really good and clear distinction. I like that. Last one, really quick one, actually. We go to see our neurologist every 6 months. We have a visit for 5 minutes. She says she's okay. Come back in 6 months. I'm not sure if she's looking for something, but I feel like we're just being brushed off. Should I seek out a second opinion?
I think from a neurology perspective, it's always helpful to seek a second opinion. And I would say, actually, probably not just from a neurology perspective. I think that if you're ever not happy or not feeling satisfied with healthcare, it's always valuable to get a second opinion. Your child is your child, and you're the best advocate for them. So I think that if it's something where you're not feeling comfortable, seeing if other parents have recommendations or other providers are willing to meet with you. It might also be helpful just speaking with that provider directly as well, sending them a message if possible ahead of time, saying that you'd like to be able to spend some more time discussing your concerns and making sure that that's worked into the appointment too. But again, you're your child's best advocate.
I think that's echoed yesterday and now it's echoed today. I like that a lot. So I think we want to thank Dr. Berger for joining us today.
My pleasure. Thank you so much.
And we will put her contact information or the contact information she's willing to share in the app so that you can connect with her.